In the 2007, the Institute of Medicine published a report on the healthcare system, and essentially this issue of whether our healthcare system actually is getting better over time. And the conclusion was that the nation needs a healthcare system that learns. We have to be able to learn from either experimental or observational experience with patients so we get better over time treating them. This requires a new clinical research paradigm, and we can leverage the electronic health record systems that we have and bring together practitioners and researchers, sort of narrow this distinction between research and practice to help the system get better. So I want to introduce this concept of a pragmatic clinical trial, which is a trial that's intended as closely as possible to reflect routine clinical practice, so that it has increased external validity. What you see in that trial is more likely to reflect what you'd see in actual practice. And we want, to the extent possible, to maintain the rigor of a randomized clinical trial, but there may be some things that are hard, like blinding patients to what treatment they receive may be very difficult in a pragmatic setting. So this is not to be confused with the concept of large, simple trials, which was, I see as primarily a British concept, was this idea of randomizing many patients to two simple treatments, collecting very sparse amounts of data, and then hoping at the end you can sort it out. This pragmatic trial can be very complicated if the clinical setting in which it's conducted is inherently complicated. So the quintessential ambulatory care model for doing pragmatic clinical trials is something called a practice-based research network. And how many of you are familiar with this term? Okay, so a few. So a practice-based research network is intended to be an infrastructure for conducting clinical research studies. They may be observational, they may be interventional, in what I would consider a way that's as low impact on the practice as possible, but that is not zero impact. And one of the first of these was done by primary care pediatricians, and they answered some very vexing questions about how best to treat very young infants with fevers in ways that really couldn't be done at academic centers, because the academic centers were non-representative. The skill of the practitioners was different, which was actually very important in that particular context, and they needed a very large sample size. So that was a real success story for this. So this creates data that's maximal validity for practitioners and may be quite cost-effective, especially if you have a cadre of practitioners who share software. Therefore, you can have some systems for integrating and assembling research data quickly. So I did a literature search that consisted of putting, I think, dentistry and practice-based research networks. And it turns out there is one. In fact, there's 3 practice-based research networks in dentistry. Were you guys aware of this? No, okay. So these receive funding from a variety of agencies. They're federally funded. They actually have a clinical research organization that provides logistical and statistical support to the research efforts. This particular one, which is called Precedent, is in the Washington, Oregon, Utah, northwest United States area. And they're doing a number of studies. But the basic idea is that the practitioners identify the questions most important to their practice. They agree to answer them in a single coherent way, including randomization of subjects and collection of data and follow-up. And because there's a large number of practitioners involved, although there is definitely additional work for a practitioner that takes away from their normal workday, okay, so there's a real cost to it. At the end of the day, the goal is to get these questions answered and move on. So it's really it's a strength in numbers. Okay. So one of the studies that they're doing is MTA versus, I guess it's calcium hydroxide in direct pulp capping. Does this have any relevance to your practice? I don't. Okay. It's as close as I could get. Okay. So controversy exists over what is the best direct pulp capping agent. A little bit about what it is. Our study intends to compare 2 of these materials, calcium hydroxide and mineral trioxide aggregate, both FDA-approved products. By the way, one of the key factors in a pragmatic clinical trial is you're generally comparing treatments that are not experimental in the sense that they're already out in routine clinical practice. So this is a good example of a pragmatic clinical trial to determine if one performs better than the other at maintaining the health of the tooth. The study will enroll 640 patients, and treated teeth will be followed over 2 years to determine how well they respond. That follow-up seems a little short to me, okay? But it's not a bad study design, right? 640 patients that are randomized probably will give you some useful information about whether one treatment leads to better longevity than the other. Now, I gather there was an effort to do something sort of similar to this within the TDO community. What was the sample size you were shooting for?
2,500.
Let's see, there were
50 times 50. It was 2,000 or 2,500.
Yeah.
Okay, well, that was very ambitious. Okay, so you're shooting for 2,500 patients, and how many did you successfully randomize?
60.
About 60. So 60 divided by 2,500 is a small percentage. Okay, so it's a sore. Oh.
Don't get me going.
Okay. So this is absolutely typical of attempts to do randomized clinical trials if you don't have a lot of people working with you who know how hard it is. Most clinical trials never randomize the patient population they intend. Most conclude without providing any meaningful data. Okay? So there are ways to do them so that they are highly likely to be successful, but this doesn't surprise me, and I apologize for rubbing salt or one of these two minerals in a wound. Okay, but this is the plan. So let's look and see how they did. So lo and behold, there's a publication called Comparison of These Two Agents for Direct Pulp Capping, a practice-based research network randomized clinical trial. Notice that the authorship is for the Northwest Practice-Based Research Collaborative. This is inherently an activity in which people have to give up the individual ego things. There's probably someone on the author list buried who really loves one of these over the other and vice versa. They may fight or arm wrestle at social events, but you can't tell. They managed to put that aside and get this done. Okay? So what does it say here? First of all, so there are 35 practices were randomized. So what they actually did is they randomized at the practice level. This is called a cluster randomized trial. So each practice had a single way of doing things, but because the practices were randomized, you can generate a population that is more comparable than if you let practices just decide on their own what they were going to do. There are some challenges in analyzing data from cluster randomized trials. You lose some power relative to what you would get if you randomized at the patient level. But it's a good practical compromise if people are unlikely to be able to randomize at the individual level. The difference is in a individual randomized trial, someone signs a consent form that says you will be, your treatment will be chosen randomly, like flipping a coin, and then you have to explain to them why that's okay. In a cluster randomized trial, you may say, we're doing a comparison. Some of the practices are doing this. Our practice is doing this other thing. This is what this is what we're doing, and we'll follow you up. And that may be easier for people to become comfortable with. I'm not sure it's really different because if they'd gone to another practice, they would have gotten the other treatment. Okay, and then the primary outcomes that were the need for extraction or root canal therapy. So that's a reasonably patient-centered outcome. So 43 dental practices were enrolled and randomized. This is a form of a consort diagram. 24 practices were assigned to the calcium hydroxide. They excluded some. 19 practices were randomly assigned to MTA. There were so many patients. So look at the number of patients. There's 190 patients on the left-hand column and 211 on the right. And if you do the math and add that up, that seems very close to 401 to me. Okay, does that seem right? Okay, so it says my battery is running low. I guess I'm going to run out of time in a second. So they didn't get their planned sample size. Their planned sample size, I believe, was 640, didn't we see? Yeah, so they didn't get there either. But I'm sorry, they did a lot better than you did. Okay. And And so of the people they enrolled, they also had really remarkable follow-up. So of the 190 patients who received calcium hydroxide, 175 were included in the primary analysis of the 211, 183. That's actually pretty good. It's not as good as you'd like, but it's not bad. This is pretty high-quality data that informs this treatment choice that's enabled by the teamwork that's represented by the Practice-Based Research Network. This is a set of Kaplan-Meier survival curves, or failure probability curves, that show that there is an increased rate of failure associated with the calcium hydroxide over time. One thing I don't like about Kaplan-Meier curves is that they tend to be presented this way without measures of uncertainty around each curve. And so the number of patients that are followed out to the 24 and 30 months where it really looks like they're coming apart, that's a patient or two. There's huge uncertainty in those curves. So there's a little bit of an art to looking at these and realizing what's likely to represent a difference that's unlikely to occur by chance. This is statistically significant. But my fourth take-home point is that I think the way forward for your specialty is actually not to have individual academic centers start to do better trials. That would be nice, it would be useful, but I don't think that's going to be the paradigm shifting thing. I think you have a remarkably vibrant academic, intellectual, and clinical community. And what you really need to figure out is if you have the personal fortitude and tolerance and willingness to do volunteer work on behalf of future patients, which is what it is, to create a practice-based research network and use the software that you share in order to allow yourself to actually randomize patients among therapies, some of which you wouldn't personally recommend, but for which there's enough uncertainty in the community to make randomization ethical, and then follow those outcomes so that a year from now or 2 years or 3 years from now, instead of talking about the same controversies, you talk about, wow, we learned that this choice doesn't matter because the outcomes are similar enough, or this choice does matter. And then your conversation at your scientific assembly could be about what the next trial to do is. Because one thing that I would love to have you do is, instead of being the recipients of people talking to, at, or with you, depending on how you look at it, would be having a discussion where what we're all doing is working together to design the trial that you all are going to do. I think that would be exciting, and I think that that's the way to carry your specialty forward, and frankly to distinguish itself from other parts of the dental professions. So I think the challenge is to come up with something, and I don't know whether it's comparison of preservation using your techniques versus implants. I don't know if it's minimally invasive versus traditional. I don't know if it's choice of material. That requires the domain expertise that you have. But what I know is whatever the questions are, you're going to have to be willing to do prospective randomized work to answer them at this point. So this is actually my transition slide. This is a famous saying attributed to Yogi Berra. He himself is actually not sure that he said it, but I know he liked it, which is, when you come to a fork in the road, take it. Anybody know the context for this saying? I know you can all look it up faster than I can remember. So apparently he was giving instructions to a friend of his how to get to his house. And what he really meant is that there's a decision point in the road, and instead of going straight, you should take it. It actually wasn't as dumb as it sounds. Okay? But it works much better, especially with the odd graphic to the left. So what we can do at this point is we're going to move to question and answer. I'd be happy, and I know Sander and the other speakers would be happy to talk about any topics. This is my list of things I'd be happy to talk about. And I'd be happy to address any critique, criticism, or discomfort with any of the points that I made. Okay, yes, sir.
When you were talking about the intention to treat and how you could misinterpret the data based on when people aren't treated, or they analyze the database not on how they were intended to treat, but how they were actually treated.
Yes.
Wouldn't it is it of any benefit to just throw out those? I mean, I know that's a, anyway, is it?
Yeah, so the question is with the intention to treat principle, as opposed to retaining people in the group to which they are originally assigned, is there any benefit in just ignoring people who didn't continue with the treatment that to which they were originally assigned. So just deleting them from the analysis instead of putting them in the other. So that reduces the magnitude in general of the bias that I'm concerned about. It doesn't eliminate it, but it still doesn't get you at the answer that I think you're trying to get at, which is when I have a patient in front of me, if I recommend one thing, what on average is their outcome going to be? And if I recommend something different, on average, what is their outcome going to be? You want to know the difference between those two average outcomes. And if it's positive, I'm going to choose one. If it's negative, I'm going to choose the other. And only the analysis by the intention to treat principle, the way I suggested it, gets you closer to that than any of the other choices that we've talked about. And the reason I'm being a little bit careful with my wording there is Sandra actually came up and pointed out that I had oversimplified several things in my intention to treat. But my point here is that you're going to have to keep patients in the groups to which they are originally assigned and not lose track of them and not count them just because they didn't go along with what you said or you weren't successful in doing the treatment. Okay.
I've seen literature give both intention to treat and per protocol analysis too. Is that another way to kind of address that issue?
So it depends on the context. So if you're early on in clinical development and there's an inherent interest in the actual biologic activity of the agent, and you're not actually trying to inform clinical practice, then there's quite a bit of scientific interest in the per protocol. It's like, if we did this perfectly, does it do anything? Okay? That doesn't tell you whether it's going to work in clinical practice. So that's a per protocol analysis. The intention to treat principle gives you a better estimate of the effect in actual clinical practice, taking into account these issues with compliance and ability to perform technical tasks. So that's more informative for clinical practice. It's not really an exception to that, but it's an additional point, is that if you think about non-compliance, let's suppose you have two treatments, one of which works really well. Okay, I used to use dicloxacillin. Anybody remember this drug?
You told us this.
I have very few stories. Okay, okay. So just be quiet. So dicloxacillin, antibiotic, was an oral liquid. It was very good against staph, and it was the most vile tasting stuff in the world. And the typical example, have you ever seen the internet? I don't think I used this story. You ever seen the internet stories about how to give a pill to a cat? Okay. So it starts out by various things, and then it says you do this, and then after you get all of your wounds sewed up, you go back, you try this, and then when you get the house rebuilt. And the point is, you're never going to get a pill into a cat. Okay. Well, giving dicloxacillin to children, was exactly like that. There is no physical way, unless the child is anesthetized, to get that stuff in. So the compliance with dicloxacillin was very low, and its effectiveness, not efficacy, its effectiveness was very low because parents, no parent, if you call them up on day 3, would admit they were even trying to give it anymore. They're like, what the hell did you give me? Okay? So other drugs that were biologically maybe less effective or maybe had the same effect were much better because the kids would actually take it. Oh, they like the pink one. Okay? So the point here is that let's suppose hypothetically you have one drug that works and one drug that doesn't, but this one tastes horrible. Then in intention to treat, this one doesn't work because no one takes it, and now they look the same even though they're both ineffective. Why does this matter? Because if you're doing a non-inferiority or equivalence study where the null hypothesis is that they're inferior or different in those two cases, and you're trying to prove that they're the same, you can artificially make a bad drug, make a good and bad drug look the same if everybody is non-compliant, because everybody has no effect. So one of the situations in which you care about the per protocol analysis, I'm actually trying to answer your question, is in the setting of a non-inferiority or an equivalence design, in which case you want both the ITT and the per protocol, and you're looking for consistency of the estimates of treatment effect. And if they are inconsistent, then the result is much more difficult to interpret. Doesn't mean the per protocol has primacy. It means that they need to be consistent for the result of the trial to be interpretable. Okay? So, so non-inferiority and equivalence designs, you want to see both intention to treat and per protocol in general. Okay. I'll go to the back, and then I'm going to actually I've actually been ignoring you. It's actually not on purpose. We're going to go here, then to you, then here, and then I wonder if Sandra had a comment on what I just said. Sir.
Could you maybe give us an example of a procedure in emergency room medicine that you used to do, but based on studies, you don't do or do markedly different than you did before? And maybe talk about those kinds of stuff. Because essentially, that's a lot of what we're talking about.
Yeah.
Most of us do what we do because that's what we've been doing, and we've told ourselves it works.
So there are lots of things we do differently now, but they tend to be, so I'll give you an example. Blunt abdominal trauma, we're worried about intraperitoneal hemorrhage, and the patient is too unstable to send to the CAT scan. This is actually a pretty common scenario. And the question is, are they bleeding to death with intra-abdominally or not? Because if they are, they need to go to the operating room or they'll die. And if they aren't, putting them under general anesthesia is really bad because then they get no benefit and they get the risk. Okay? So our diagnostic strategy for identifying life-threatening intraperitoneal hemorrhage used to be we would do something called diagnostic peritoneal lavage. We make a little cut, we dissect down, we get to the peritoneal cavity, we build a little tube in, and we basically suck and see if there's blood. Okay? Did that in the 80s. Okay? Then it turns out ultrasound machines of better and better portability and accuracy became available. And research was done that showed that if you had enough blood in the belly to be leading to hemorrhagic shock, that these ultrasound machines would show it to you with enough sensitivity so you didn't have to cut into the belly. So now nobody remembers how to do that except for the old surgeons and people like me. We would never do it. We do it completely different. My impression is that we are more comfortable with changing our practice paradigm than you all are. This is just a general impression. It would be happy to be wrong, but I can tell you that medicine, at least certainly in my specialty, but also in my wife's specialty, we've just gotten to this idea that stuff changes every few years, that there's going to be some major change every year or two in some aspect of what we do. Now, the diseases that I treat in the clinical settings are more diverse than the diseases you treat. Okay, so that maybe that's why there may be less change over time. But the drugs we use for sedation, the antibiotics we use, the amount of fluid that we give in patients with septic shock, all of those things have changed in the last couple of years. And we're just used to it. And I think that's healthy to sort of let go of believing that the way you were taught was right. Were you guys taught the same thing we were, which is half of what you're taught in medical school is wrong? Okay, and then when the medical student looks like what, and then they say, but we don't know which half. And then, I don't know about your school, and mine was, and we will test you on all of it. So I think that's an important sort of philosophy to realize that stuff really needs to be changing. There was a question over here. Okay. Yes.
If you do a randomized trial in an academic setting, you need an ethical committee to do that. So my question is, if this group decided to do a randomized prospective study, is there a first of all, outside an academic setting, is there a uniform?
Sure. So the way is how to handle the ethics committee review, the institutional review board. So now the standard in these multi-center trials is to use a centralized IRB. There's 3 or 4. There's a whole bunch of them.
Sorry, I don't think that's my question. Is this group is outside the university? This is not university.
I'm going to finish, and then you tell me if I answered your question. Okay. So there's centralized IRBs. One of them, I have no financial affiliation, but it's very well respected. It's called WERB. It's Western IRB, but they handle trials all over. And they're recognized as being both efficient and having very reproducible standards for review. So what you would do is you would put your protocol together, and you would submit it to WERB, And they would review it once and say, this looks okay, this doesn't look okay, I think you need to characterize this risk to the patient a little differently. You get it approved. Then anybody else who wants to participate simply refers to the fact that it has been approved by that central IRB. If you happen to be at an academic center, I think you will find that your local IRB recognizes the authority of WERB and will simply give you a reciprocity approval. If you're not in an academic setting, that still counts as your ethics review. Did I miss it? No. Okay. Yes, sir.
I'm just fascinated by both presentations, first of all, but the comments where more times you do a study, less likely to get an answer.
So I
So it gives your presentation where you showed 5 studies, p-value 0.1, and then you do the math, and all of a sudden you have that significant statistically. And then if you do 20 studies,
Yeah, but the error could be larger.
yeah. So I think I'm going to try to.
what's going on?
Okay. So think about a setting where trying to come up with a good example where you have. I think Sandra gave the example. I'm simply going to use the example you do. You have a bunch of little tiny studies, each one of which has one patient get one treatment and one patient get the other. And in every one, people who get treatment A are happy. People treatment B, their mouth just falls apart. Okay? And you do that over and over and over and over and over again. But every one gives the same result. Okay? The first one might be chance. The second one might be chance. But we all agree there's some number where you go, wow, this is pretty compelling, okay? And it'd be interesting to know what that number is for Sander. For most people, it's between 5 and 10, okay? And almost nobody would go through 100 pairs where every time it's that way and say there's still residual substantial uncertainty, okay? And yet every one of those little studies would be considered negative. So the way I interpreted Sanders' example was that those series of 0.1 p-values were all in the same direction. They were not random. It wasn't half of them in one direction and half of them or the other. Yeah, that's why he. So remember he said, I normally do two-tailed, but this time I'm doing one?
I don't normally use two-tailed. In this case, I'm going to use one-tailed.
Okay.
I think they should be used as appropriate.
Okay.
No.
So that was the scenario. So it wasn't that they were all non-significant. It was they were all non-significant and trending a little bit in the same direction. So there was some consistency of evidence that when you put it all together became compelling, just like my series of 100 N of 2 trials is compelling if everyone gave the same answer.
So meta-analysis?
Exactly. With proper meta-analysis. I mean, not where the informal kind where they report and say, majority of studies have reported finding nothing. That's because their criterion for finding nothing was greater than 0.05. That's very good.
Okay. Other questions? Yes, sir.
With a group study, like sort of an outcome study type, is there a sweet spot for the number of practitioners and the amount of treatments? Like if you have 1,000 practitioners and they just do one of one arm and one of the other, is that different from 250 practitioners doing 4 of one arm and 4 of the other?
That's a great question. So there's multiple considerations. Sander and I may take this from different points of view. As a general rule, this is another quote if someone's going to look up where this comes from, that there's no data like more data. Okay? So as a general rule, your sources of variability come from the variability within patients and comes from the variability within practitioners. You may be better at the minimally invasive technique than the standard, and you may be better at the standard than minimally invasive. So as a general rule, the more variety you have, so the larger sample in both practitioner and patient, the more information that you have. So if you gave me that choice, if you gave me 4 practitioners each enrolling 250 patients versus 1,000 practitioners each enrolling 1, I'd probably rather have 1,000 practitioners each enrolling 1. I'm not totally happy with that, but that I would. The reason I'm not totally happy with that is because there's a learning curve in doing clinical research. And often the first person, you don't have the same data quality, your technical approach to the approach you don't normally use isn't different. So there are some practical considerations and some logistical ones. Sandra, what would you say to that question?
Well, somebody asked it, basically, maybe it's simple, at one of the breaks, asked that very question.
There's a mic if you want.
Oh, okay. Let me,
He was highly relaxed
we are in San Diego.
until I called him out. Okay.
But my answer would be, it's complicated. It's complicated. I mean, you said you only had 1 in each practice. Well, then you've got all kinds of practice effects, and do you want them there? And there's no sharp boundary, and it would depend on the context. I had to say, this is one of those things where I would be afraid to give a simple answer, because a simple answer would be bound to be wrong in some setting.
So I'm more comfortable being wrong than Sandra is. Okay. Okay.
Probably.
So in a practical sense, as long as the study gets done, because no one is not better.
Well, I don't want to be that wrong. Okay. So there are some answers that are going to make, I think, both of us uncomfortable. The 4 practitioners with 250 each, that makes me very uncomfortable, because what if 3 of them are really good at one therapy and only 1 is good at the other? That could drive the outcome, okay, and not reflect the inherent effect of the treatment. The 1 patient in each of 1,000 practices makes both of us uncomfortable because of this confounding of practice characteristics with patient characteristics that they're very problematic. So there's something in the middle, but what I would love is to get you to the point where that's what we're discussing. How should we do this, as opposed to what model do we think, these are the good discussions to have in the specialty. There was someone else over here, I believe. Yes, sir.
So it's kind of a general question. So I would say that most people in our profession we don't have a firm grasp of a lot of the statistics used in a lot of the studies we read. So, and we're trying to learn certain things, but how does like a well-intended clinician read a study in a journal and know, is this a valid study? Is this not a valid study? I mean, aside from certain obvious things like sample size, like what?
So what do you look for in a study? Yeah.
Should we be looking for to know, is this good, is this bad?
So there is I think last time I did it, I had slides, and I don't know if I presented them, on how to do a retrospective chart review, which essentially talks about what affects the validity of a retrospective study. So retrospective studies have all kinds of problems, but even within that, they can be done pretty well or exactly the opposite. But that said, I think it is really tough. I used to give lectures on how to read the medical literature, and I stopped doing it not only because they were boring for everybody, but because it was like Sanders last, everything I said, I would say one thing and think of 10 exceptions, and it just started to feel like it was a level of simplification that wasn't completely intellectually honest. So I don't know, this Journal of Endodontics, okay, is a peer-reviewed journal. Is that sort of the highest rated journal within your specialty? Okay. So I looked through both of those a little bit. Yeah, it's horrible. Okay. Yeah. 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 So there are such profound problems with your literature basis that it's profoundly depressing. and yeah, and so really what we should be thinking about is how to get out of this rut. Okay, I mean, it was like the comment that was, I sort of challenged you all, would you send, someone you cared about to a random well-trained endodontist? And I mean, there wasn't anybody, okay? And I made the comment about physicians. Sanders said that he was going to make the comment that he feels the same way about random referrals to statisticians, okay? Okay. But that said, there are things that one can do as an intellectual community to improve the, you don't have to go from 0 to 200 in 6 seconds. There are things you can do to improve stuff, but one of the things that you should be doing is insisting that the research work that is done collaboratively with people with greater expertise in research methodology. And there are fields of medicine that I don't want to call out, like family medicine, where they're in a very similar position, and the way they're going to bring themselves up is, so for the family practitioners, there's a tremendous intellectual capital in pragmatic clinical trials and good observational research techniques within general internal medicine. Okay, just the Robert Wood Johnson program has had a lot of positive things. The family practitioners who see many of the same patients need to team up with the general internal medicine people and work together, in my view, okay? To bring themselves up and to create, what you need is a journal that has very good peer review, many of which will not be by endodontists, who set a high standard, and it becomes clear that something in that journal is likely to be of a higher methodologic quality. And so as opposed to telling people what they should look for in a research study, which I used to do, what I actually say now is that there really are several different tiers of journals within medicine, and certainly within my field. And you can be pretty sure that something published in New England Journal and JAMA has been pretty well reviewed and is pretty high quality. Is it perfect? No. Do they sometimes make blunders? Absolutely. Do they sometimes publish stuff because it's really cool to get, because their readership is based on news and web hits? Absolutely. But on average, it's better than stuff that's published in lower level journals. In emergency medicine, there's a journal called Annals of Emergency Medicine, and Dave Schreiger is one of the key methodologists for it. It's just someone Sandra knows, that we both know. And they do an incredibly good job of methodology review, and their stuff is awfully good. And you just know it. So it's almost a faith in the quality of the machine, as opposed to each individual reader trying to generate the expertise to make those decisions. I'm a methodology reviewer for JAMA, and I review the articles that the peer reviewers had trouble knowing whether the methodology was okay. That's what I get. And we do that because we don't expect the readership of JAMA to be able to make these judgments. Plus, we don't want to publish anything that's faulty if possible. Yes, sir?
So when you review the methodology, is that done before the study gets done?
No. We're reviewing stuff that's been submitted for publication. Most of the research that we review has been federally funded or is funded by entities that have a vested interest in doing a very high level of initial review. So if it's an NIH-funded study, the NIH has a very well-structured peer review process. If it's funded by a for-profit company, for-profit companies, because of the way the incentives are aligned, have a vested interest in not funding research that's of poor quality, because the FDA won't pay any attention to it. So those actually tend to be methodologically pretty good as well. I mean, there are biases and there's weaknesses, but they tend to be pretty high-quality studies, but we're not doing the pre-study review. Okay, other questions? Yes, sir?
Do you think most physicians from their training in medical school have the ability to read the literature at a higher level than what you would see with this group of people? I mean, can they tell what's good and bad, what's a throwaway, what's to go through all of the things which you've talked about today?
I have no evidence that they're any better.
But they're really depending on the quality of the journal to tell them whether this is something to pay attention to or just to discard?
Well, it's actually kind of even worse than that. So there was this charade that we all went through early on in our medical training, which was pretending we read the primary literature. We were all told everybody in medical school has to learn the primary literature, all the young doctors in training. We never did that, okay? We were tired, unless there was a good reason, we looked in a textbook. The textbooks were 5 to 10 years old. They were written by people with very strong opinions. They were key opinion leaders. You had no idea what references they had chosen not to include or cite or include in their thought process, and that's just the way it was. And then for those of us who stayed in academics, in the particular area that we're interested in, so for me it might be septic shock, you would read the primary literature because you were involved in research activities or lecturing in that area. Now what we see is that almost all practitioners, and especially the people in training, remember they're young by my standards, they're going to secondary syntheses of literature. So they do not look at primary literature anymore. You know, I have PubMed on all of our computers. I can pull up primary literature in 10 seconds, but they can get to a synthesized, condensed millennial-length version, okay, of whatever it is. And I want to sit down and talk for 10 minutes on the optimal therapy of such, and they have a paragraph. Oh, it says we should do B. And the frustration, which I'm probably projecting, which some of the more traditional academics feel, is that they don't seem that interested to want to know how that little website came up with the recommendation to use treatment B. They just want to get to the answer. And so I used to be concerned about the fact that practitioners and even many academicians didn't know how to read primary literature. Now what I'm concerned about is that no one is even interested in reading primary literature, so that the synthesis role going from primary literature to these condensed treatment recommendations on websites, okay, that is becoming a critically important piece of the healthcare system. And the thing that I'm happy to see is that there now is an increasing level of peer review in that. So there's some UpToDate. I don't know if you guys have a version of UpToDate. Okay, so UpToDate is a website. They make an ungodly amount of money. And what they do is they synthesize primary literature and come up with little vignettes on how to take care of, you know, streptococcal toxic shock or, you know, malathion poisoning or whatever it is. And when it first came out, it was written by people I'd never heard of. And over the years, people who used to be the editors of textbooks and the lecturers and some of the researchers have started to move over and are now editing these online resources. And that's a really, really good thing, because what's happening is that the expertise is shifting towards the information path between the primary literature to the trainees and the practitioners. And we need that, because we need the you know, not skeptics the way that Sandra was talking about skeptics, but we need people who are experienced in reading the primary literature and trying to separate the higher quality information from the information that does not need to be included, if that makes sense. That's a very long-winded answer. Okay. Other questions? Yes, sir. Well, every generation of physicians is scared about the next generation. I think that's just a tradition in the specialty. Okay. There are things, I mean, it's a very broad question. If we're talking about information, the use of information is becoming much more fluid and sort of integrated into medical care, because we used to priding ourselves on memorizing stuff and thinking we remembered it right, whereas now there's much less value placed on memorizing things and a much higher value placed on having a handheld device that has every, you know, dictionary or algorithm or thing that's necessary. So that's actually a really good thing. The thing that is getting lost, and I'm not sure that's that applicable for your specialty, but certainly in medicine, is that there's been such an emphasis on lifestyle and work hours restrictions that the standard patient who's pretty ill in the hospital, instead of being treated by one person who's sleep deprived but saw them on day 1 and day 2 and day 3, it's being replaced by a series of bright-eyed, bushy-tailed, and well-rested physicians who have no idea who the hell you are or what you look like or why you're there. And we have not solved the cognitive problem of how to hand over or transition responsibility of care in a way that doesn't entail risks. So there's a whole safety literature and work on the so-called handoff, the safety of the handoff. And what we're finding is that the handoff is a very risky thing for the patient because information gets lost. And our new way of providing medical care through, for example, hospital systems involve lots and lots and lots of handoffs. And this is something where it actually ties to some of the logical stuff we've been talking about. We remember the Libby Zion case? Okay, Libby Zion was a very unfortunate young woman who was treated in a New York hospital. And I believe she had a drug overdose or a drug adverse reaction, and she was in the hospital for that. And the nurse was concerned about, this is a very vague remembrance of this, was concerned about her condition worsening and kept calling the resident physician on call who was in charge of her care. And the resident kept saying, just do this, just never went and saw her. And her care was worsening, and she died. And she died, I think most people believe she died unnecessarily. And the reason the resident didn't respond was not because they were an evil person. They'd been on call for something like 36 or 48 hours. They were just too tired to think clearly. So that led in a reactionary way to an assumption that the solution was to make sure physicians were well rested. Which, I mean, it seems like it's sort of a mom and apple pie thing. It seems like that a well-rested physician is going to make better decisions than a tired physician. And just like the picture I gave earlier where I said simple hypotheses are dangerous because sometimes the system is much more complicated than you think, what's happened is we have and this is legislated work hours restrictions and training programs, and absolutely the residents are well rested and they look much happier than I was in training. There's no question we've achieved that, okay? But they have many fewer contacts with patients. They know less. They see it as it's sort of a job like I might have a job selling clothes, but when I leave, I don't worry about the economic viability of the store because I'm just the sales clerk. It seems much less as a calling and more like an occupation. And that's okay, and I think the mental health of the physicians is better, but there are real potential effects on patients in certain situations that worry me. That's what worries me. Again, a very long-winded answer. Yes, sir.
When you were talking about this thing, the hospital model of being compensated by how quickly they can, or the lack of any complications, why doesn't that end up with just physicians or hospital just not treating the most difficult cases? I mean, if I was being paid by just simply by getting people out of the hospital earlier, or I wouldn't take any tough cases. I'd just do the easy cases. So what happens to those patients that you probably will have complications if you're compensated that way? How does that work?
So setting up economic incentives to motivate the behaviors you want among professionals is a complicated thing. But for example, the system of compensation for hospitalized patients, the DRG system, says that if I admit a patient to the hospital who has community-acquired pneumonia, and I think these numbers I'm about to tell you are actually about right, the hospital is going to get $8,000, okay? But if that patient has comorbidities that predispose them to complications like congestive heart failure that's acute, or they require mechanical ventilation on admission, then they're going to get paid either 1.5 or twice that amount. So there's an economic incentive for being willing to take on the harder cases. However, if I admit the patient and then they require mechanical ventilation later and end up with a ventilator-associated pneumonia, which is a complication that's preventable, I don't get any extra money for treating them the extra days for that additional type of pneumonia. So the idea is to set up financial incentives that fairly compensate, or if you'd like, incentivize you to take care of everybody, and acknowledge that the patients who have poor prognosis or more complex medical conditions or are more medically fragile are harder to take care of. So there's multipliers. And then to have a disincentive based on anything that should have been a preventable complication, so that physicians focus on increasing the safety of care by consciously doing things to reduce those complications. So for example, if I'm critically ill and I require a central venous catheter, so a catheter, it often goes in the neck or under the clavicle into the central venous circulation, those can be very useful for managing patients in certain situations, artificial nutrition, measuring central pressures, et cetera. But they have a risk of infection that is a per day risk. Every day you leave them in, the risk the patient will get an infection goes up, and if they get infected, they're going to need 10 days of IV antibiotics. Okay? So there's a financial incentive based on whether or not you document every day why that line is still in there. It's to force physicians every day to ask themselves, and we have big signs posted, does the patient still need that central line? So that you absolutely consciously do it, take it out if it doesn't need to be there, because the observed behavior was we tended to forget about it for a few days. We'd come in over the weekend and we'd come in back on Monday and say, oh my God, they still have the central line in. We haven't been using it since Friday. Okay? So these are incentive systems put in place to change thought processes and habits and behaviors to improve the effectiveness and safety of care. That's a good thing. So I think it's important to not let the perfect be the enemy of the very good. So the perfect might be that we are all wake up tomorrow financially independent, with infallible memories and never make a mistake and are motivated by only doing what's best for our patients, and we actually know what that is. Okay? Okay. That's unlikely to happen. Okay? So the reality is, how, if I'm part of a reimburser, whether it's an insurer or CMS, sets Medicare reimbursement policies, I have a certain amount of money that if I'm well-intentioned, I want to use to improve the average health outcome of the population that I serve. And the question is, and it's a finite resource, and you may, I think this gentleman doesn't like insurers, but many insurers really think about it in terms of, we have this much money, and yes, they need to keep their stock up and all that, but what are they going to do to maintain the health of the population? And it actually doesn't work to disincentivize appropriate care for patients, because then your patients, who you're still responsible for as insurer, come back and need repeat care. That's not a good strategy from an insurer point of view. And so I had this slide where I said that the outcomes of interest for patients and parents and practitioners insurance really should be the same. They really are more the same than people think they are as we move towards capitated care. The problem with some of the previous structures for insurance is that the financial incentives were divergent, and that actually had its own problems. Like if I mistreated a patient and they require, I forgot to take out the urinary catheter and they got a UTI and had to be in the hospital in the ICU for 4 more days, the hospital just made more money, right? Did anybody come down and say, Dr. Lewis, you got to get those things out? No, they said, Dr. Lewis, no problem. Okay? Okay, that's bad. Okay? Okay. Other questions? I'm obviously willing to talk about anything. Okay.
Since you're willing to talk about anything, and you're talking about CMS and population-based care,
Yes.
how is since it's October 1st, how is ICD-10 going to affect the way you practice clinically and how we receive care? And what, if anything, will the government be able to do with the additional codes that people are coding for?
Okay, so I am certainly not an expert on ICD-10, but the basic issue is that ICD-9, which is, what, 30 years old or something, was a set of codes for identifying diagnoses, and ICD-10 includes much, much more specificity and detail on sites and acuteness and subtypes of disease, so that the data created through ICD-10 coding allows much, much more detailed understanding of the disease characteristics of patients. I think that the motivation is not just to make everybody's life difficult, but to allow us or to gain a better chance when we gather diagnostic information through electronic health records to understand differences in disease that might affect outcome, in part so that mining of large observational databases can be a more nuanced and maybe productive process. I think that's the motivation. Some of it, and I still have to finish some of my ICD-10 training, is very counterintuitive. I mean, there's some examples that have been in the popular press about, someone saying, yes, now I have to code separately whether you were bitten by a parrot or a crow. So some of it's a little difficult to understand the rationale. Some areas, like in tuberculosis, there's 30 or 40 codes for different types of tuberculosis and their tuberculous infections, and then there may be some other area that's much more common that seems to have relatively few codes. So in terms of the way we deliver care, all this does is forces us to be more specific in how we record diagnoses. The concern is that the reason that CMS and insurers want us to be more specific is so they can come up with more reasons to pay less. I think there's absolutely a cost control. Now remember, when you're a practitioner and the insurers and CMS wants to pay less, we think we get paid less, which is of course what it means. And what the taxpayers think is the rate of the cost of these federally funded programs or your insurance premiums goes up more slowly. So it's two different sides of the same thing. So I do think there's some cost control, cost accounting motivation. I don't think the burden on the provision of care is that great. There's going to be a period of time, and it may be sort of the end of this calendar year, where people find that the training they got on ICD-10, the software, their billing services aren't really up to speed, and there's some delays in bills and missed bills and stuff like that, and we'll work that out. So I see it as painful, but not inherently evil.
So perhaps I misunderstood, but I thought you were telling us that observational data is not very good.
So what I said was that observational data is not very good for informing treatment choice. But so, for example, let's say I want to understand the burden of disease in a population to make sure that the providers in that area, that I know where there are shortages of providers. Okay, so there's a lot of questions for which observational data are incredibly useful. But what I was really focusing on was this question of how to choose the right treatment for a tooth in a patient. And it seemed to me that you have taken observational data as far as it'll go for that. Okay, yes, sir.
That kind of leads into what I was thinking about. We do root canals for a variety of kind of stratified conditions. And if we did a trial and we would record the preoperative diagnosis based on whatever the agreement is in the group of where along the spectrum they are. When you obtain all the data, what can you say about, because there was some studies quoted earlier, and we've all been indoctrinated by the preoperative condition affects the success rate of the treatment. Mm-hmm. So would we be able to speak to that from a study of that type?
So the preoperative condition potentially affects two very different things. It affects the overall prognosis for the tooth. Okay, I'm sure you all look at teeth, you say, oh, this is a pretty good candidate. And I'm sure you all look at teeth and you go, oh, no, right? So that's a general prognostic indicator. You want to record that before the randomized treatment assignment because you're going to use that in your analysis to adjust for any imbalance in the average sort of teeth status in the different treatment groups. The second question, which is more subtle, and I think these are easy for people to confuse, is the question of whether teeth in different categories should have different treatment recommendations. Okay? So for example, and I'm just making it up, you could have the finding that for patients with earlier stage disease or less extensive disease, the minimally invasive approach is better. It preserves more dentin, the tooth lives long, and you don't figure it out till 15 or 20 years of follow-up because those teeth just really do well. Okay, but the minimum is better. You might find in the same study that for the patients with the more severe disease, the traditional approach is better. And those teeth on average aren't going to last as long. They had more severe disease. But in fact, given that you don't control what disease the tooth is at when it presents to you, okay, that given what you have to work with, the traditional approach is better. So that would be an example of heterogeneity of treatment effect because the direction of the treatment effect is different based on the illness severity or the stage of illness. And so you'd want to record it and you'd want to design your analysis plan so if that were true, you are going to be able to detect that. And that was that comment I made, is the average effect important? The average effect may not apply to anybody. You may need to be thinking about patients with different types of disease in stage or location as different kinds of patients. Yes, sir.
So I think that's a great example, but I don't know that we can come up with, as a group, all of those questions that we might ask. So how will we go about doing it in an exploratory fashion?
So I don't think the goal is to try to design a study to answer every question. But the goal is to come up with a study that answers questions that the community as a group think are the most pressing questions. And then for those of you who disagree with that choice, because there will be some of you who disagree with it, to create a community that reinforces being quiet about it and being a good team player and getting those questions answered. So 3 years from now, you're on the in and you can say, now I'd really like to answer this question. And people say, well, we knew you didn't really like our first question, but you helped us out, so now let's talk about your question. Right? It's this, some of the content of the presentations early in the day could suggest that they're camps. Okay? And that is just the existence of those camps and the maintenance of the barriers are not going to help you as a specialty. They may keep your blood pressure up, they may give you a reason to get up in the morning or write really nasty emails, but they're not going to actually carry your specialty forward. Okay. So then should I stop there? Is that what you're saying? Okay. Sorry.
I have a statistical question.
Okay.
For intervention or risk or carcinogen, what is the ideal way to present the data? A confidence interval, or what would you like to see?
So my answer, Sandra, you can put your shoes back on, is my answer is that what I would like to see is either a frequentist confidence interval or a Bayesian probability interval for the relative risk or the measure of risk, so that I understand, because to me, it's a good way of communicating the uncertainty in the true risk.
Yeah, I agree completely. This is the major issue. In fact, I'm looking at most of the literature, is that they didn't give interval estimates. Interval estimates not only give you a picture, if you look at them carefully, of the uncertainty, you have to look at the endpoints of those intervals. You have to say that if I'm going to take this interval the way we normally do, it's telling me it could be it's more likely to be somewhere in there, but it could be at these extremes. And a major problem with the literature is that either they don't present interval estimates or they don't for key quantities. Both those trials, those pediatric trials, lacked interval estimates for some key quantities. Even though I'd say that they were, certainly the Bellinger one was very well reported based on standards I've seen. But the interval will do you no good if you don't look at the endpoints. Too often I see where they conform to maybe some of the journal's requirements, like BMJ, put in an interval estimate, but then they just talk about it, whether it contains them all or not, so they're only using it as a significance test. And that's what you have to avoid. So, but you need that interval estimate, not only for this purpose, but also to make it easy to combine results across the study. You can do it other ways, but it's very hard. The confidence interval gives you the information you need to avoid the kind of fallacies that I was illustrating.
Yeah. Other questions?
And yes, if you set up your journals, all of them, they should start requiring confidence intervals.
Yes. Yeah. Anything else? Okay. All right.